get started. So I want to first of all thank everybody for joining the AVNeo webinar. This is our 8th webinar that we've had over the last 12 months or so. And we do definitely appreciate everybody taking the time to join the webinar. Today's webinar, we have two different professors. We have Professor Marcus Krane, who will first be talking to us about treating the bicuspid valves with AVNeo. So many of you are advanced users, have been doing AVNeo cases. We have more than 100 surgeons around the world doing AVNeo procedures. And one of the requests that I get quite often is a bit more of an advanced training. So today's webinar is really designed to be about advanced training. So I know we have a number of people that are new users or have not started the AVNeo yet. We will continue to have some more basic kind of training of the step-by-step and etc. But today's training is really designed to be a bit more advanced, and Dr. Krane will talk to us about treating bicuspid patients, which we have a large number, especially in the non-elderly patients. We have a large number of bicuspid valves that we have to repair. So Professor Krane will talk about that. And then after that, Professor Bakhutashvili from Georgia will talk about a couple of case studies that he's done where he's treated patients with infective endocarditis using AVNeo, which is a little bit different than what Professor Krane has done. So I think it'll be quite interesting to hear both of these presentations. And first off, I would like to introduce Professor Marcus Krane. Professor Krane is the Deputy Director, Adult Cardiovascular Surgery, and he's also the head of the Institute in SURE at the German Heart Center in Munich, Germany. So I would like to ask Dr. Krane to take over.
Yeah, Damon, thank you very much. I hope you all can hear me sufficiently. I will try to share my screen to start with my presentation. So can you see that, Damon? Is that?
Yes, I can.
That's fine. So as Damon mentioned, today we are talking about the treatment of bicuspid valves using AVNeo. To this end, I would start with a little bit of general background of bicuspid aortic valve, and then talking about technical aspects, how to do the AVNeo procedure in bicuspid aortic valve morphology. And at the end, I would like to talk a little bit about when to repair a bicuspid aortic valve and when to reconstruct as doing AVNeo in these patients. So first of all, so no, I can't. So nothing to conflict of interest, except that I'm a proctor for JRMDD and a proctor for Peter Duschik for this AVNeo technology. So how often does a bicuspid aortic valve occur? So the incidence is 1 to 2%. So 1 or 2 out of 100 people are suffering or have a bicuspid morphology. What are various complications which patients can suffer from? And here we have a huge variety of incidences. So in a bicuspid aortic valve morphology, 15 to 70% of the patients will suffer from an aortic stenosis. Only 1 to 3% will suffer from aortic regurgitation. And an infective endocarditis will happen between 10 and 40% of the patients, and 5% of the patients will have or develop an aortic dissections. So just that you have some numbers in mind, how often we will be confronted with a bicuspid aortic valve and what are the typical complications in these patients. So how should aortic valve, a bicuspid aortic valve be classified? The most popular classification comes from Sievers et al. And he classified the morphology following these 3 types. A type 0 has just 2 commissures, and I hope you can see my arrow, just 2 commissures. A type 1 has 1 raphe, that's the definition of that, but 2 open commissures. And the type 2 has 2 raphes and just 1 open commissure in this morphology. There's a subclassification which could be used. For the type 0, that means the orientation of the coronary ostia. So in the lateral type, both coronary ostias, one is on the one side and the other is on the other side of the 2 leaflets. The other one is that you have the anterior posterior configuration, where you have 2 commissures, but both coronary ostia are on one leaflet side. If you go for a subclassification of the type 1 bicuspid aortic valve morphology, it depends on where the raphe is sitting. So is that between the left and the right, or the right and the non, or the non and the left coronary cusp? So this type of subclassification could be done, and it's helpful to talk to each other, that we can have an idea how the valve looks like and describe that properly. So here's an example coming from the original publication from Sievers et al. For example, here you have a type 1 bicuspid aortic valve with 1 raphe. It's sitting here, as you can imagine. And here you have 2 commissures which are able to fully open. On the opposite, you have here an example for a type 2 bicuspid aortic valve. And you can see 1 raphe here and 1 raphe here. And only this commissure from the left to the non-coronary cusp is able to fully open. Here's an example for a type 0. So no raphe and 2 commissures, which are more or less able to open in this kind of morphology. So this is something we have to have in mind also if we are talking later on how to do the AVNeo procedure in this kind of patients, because it's different to treat it. So what is about the age distribution in the surgical population? And this is also the original publication from Sievers et al. Coming from 2007. And you can see that the majority of patients suffering from a bicuspid aortic valve and are presenting for surgery are younger than 60 years. So what we are doing is, if we are talking about bicuspid aortic valve patients, we are in general talking about young patients. So what kind of treatment modalities do we have to treat this kind of patients in general? Either if they are suffering from a stenosis or if they are suffering from an insufficiency. So of course we can do aortic valve replacement, surgical aortic valve replacement, using either a mechanical or biological procedures, and you can do that for both for stenosis and insufficiency. If you have an insufficient valve, of course, you can do another strategy. You can try to repair the bicuspid aortic valve, and this is something what you can see down here. This is not possible, or usually not possible, in a stenotic. Or you have a new treatment modality with AVNeo, and AVNeo could be done in both. It could be done in a stenotic aortic valve, bicuspid aortic valve, or in an insufficient bicuspid aortic valve. So what are the limitations of doing biological aortic valve replacement in this cohort? So as we have seen previously, bicuspid aortic valve patients are young patients. So we are talking about this age class between, let's say, 20 and 60 years. And in this publication from Bongion from 2015, you can see that the freedom from reoperation, the freedom from event, was much worse in this young population compared to older age classes. And 50% of the patients has to undergo reoperation after a time of around 17 years. We have looked at our own data comparing two different, or consisting out of two different prosthetic valves, the paramount valve and the trifecta valve. And as you can see, also for our population, the same was true. So patients below 50 years, after 15 years, we have a freedom from reoperation of around 30%. And in a patient who is between 50 and 65, we have a freedom from reoperation after 15 years around 50%. So biological prosthesis has the problem of degeneration. Mechanical prosthesis, on the other hand, has a problem, if you can see this here, of a high incidence of bleeding risk, but a low incidence of reoperation risk. But the bleeding risk, as all of you know, is present. So a possible alternative could be the AVNeo procedure. 2011, Professor Ozaki first time published his procedure. So the procedure to reconstruct an aortic valve with autologous pericardium is not new at that time. But what he did is an amazing body of work to standardize the procedure, that everybody is able to learn that and adapt that to his technologies. So how does the experience at the German Heart Center Munich looks like in general? So far, until September 2020, this is the last time we did an analysis of our data, was that we operated on more than 150 patients. The mean age was 53 years. And as you can see here, because of this young age, a lot of patients has a bicuspid morphology, 125 or more than 80%. Concomitant procedures have been done in 63 or 40% of the patients, and permanent pacemaker implantation after the procedure was not necessary at that time. Survival rates were quite good. So we have data now up to 4 years, and we have a survival. We just lost 3 patients over this time. Freedom from reoperation was also quite good, with a mean freedom of reoperation of almost 95% after up to 4 years. Mean pressure gradients were quite low, with a mean pressure gradient in this cohort coming from 150 patients of 8.4 millimeter mercury. And this stays more or less constant over time, up to 3 years. The same was true for the effective orifice area of 2.3 square centimeter, which ends up after 3 years with above 2 square centimeter of with 2.1 square centimeter at 3 years. So let's focus on the AVNeo and bicuspid aortic valve, because what I have shown you so far comes not only from patients suffering from a bicuspid aortic valve, this was the data of the overall population. So 152 patients, 125 have had a bicuspid aortic valve morphology. 22 has as a primary vitium regurgitation, and 103, so 80% out of that population presented with an aortic valve stenosis. What is the goal? So coming to the technical aspects in these kind of patients, what is the goal? The goal is a symmetric tricuspidization of the aortic valve. And this means if you are sizing for your leaflets, it is only allowed or should be recognized that you have only one size difference for the new leaflets. This means if you have a 25, a 27, and a 27 leaflet sized, so go for that. If you have a sizing of 25, 29, and 29, you should go for a neo-commissure. And by creating neo-commissures, you can go and achieve a symmetric aortic valve at the end. So what that means is take your time for sizing. This is very, very important to be able to create a symmetric aortic valve at the end. So here you can see an example of a heavily calcified aortic valve. This is excised. You can see the measurement of the annulus is 22. And here you can see the sizing. So the left coronary cusp is 27, the right coronary cusp is 25, and you have a 25 in the non-coronary cusp. So this is a sizing which you can accept. It's just one size difference, and you can go for these leaflet sizes. Here you have another example. This is a bicuspid aortic valve type 2. You can see one valve here and the other valve was down here. And here you have a 27 for the non-coronary cusp. You have a 29 for the left coronary cusp and a 25 for the right coronary cusp. So this is not very symmetric. And in these cases, we should go for a neocommissure. You can see that here. Then you have a 27 there. Here's the original commissure. Here's the new one. And you have a symmetric distribution of your leaflets at the end. We will come to that later on in a longer video to explain that a little bit more in detail. So AVNeo and bicuspid aortic valve, how does that work in the different types of morphology? Remember our type 0. There we have two morphologies with respect to the coronaries. We have the lateral type and we have the anterior prostate type. And if you have here the lateral type, one ostia is at one leaflet, the other is at the other one. So what you do to create a tricuspid aortic valve out of that, you have one reference of a native commissure, and you have to create by sizing two neocommissures. And by doing that, then you can implant 3 leaflets of the correct size. The most difficult one, as you can imagine, is this morphology. Because in this morphology, it could happen that it works that you have to go for 3 neocommissures, which is very, very difficult. What is about a type 1? In a type 1, we have one raphe. The usual or the mainly present type is the type which has the raphe between the left and the right coronary cusp. So in this case, you also keep this commissure for orientation. You keep the native commissure. You also, in most cases, can keep the commissure between the non and the right coronary cusp, because usually the non-coronary cusp is the largest cusp in this kind of bicuspid aortic valve. And then what you have seen in the video before, you will go for the neocommissure and create a larger left coronary cusp by putting away the commissure from the native commissure here more into the sinus of the non-coronary cusp. And by that, you will achieve a symmetric tricuspid aortic valve. So how to do that? How to create a neocommissure? And here it is another view. You have your 3 sinuses. And as you can see, this sinus is much larger, usually the non-coronary sinus. And this is usually the left coronary sinus. By creating so usually you start your reconstruction at the nadir, so the lowest part of the sinus. By creating a neocommissure, you move these starting point from this presentation more to the left, closer to this commissure. So you're starting here, in your left coronary sinus, more to the commissure, your suturing line is below the native commissure, and you come up again, creating here the neocommissure, and have the new nadir of the non-coronary cusp also moved away from the native commissure. By that, your new commissure, your neocommissure, is sitting next to the native one. I hope this is, you can understand that. So for that purpose here, you can see another movie. This is a little bit longer to explain that a little bit more in detail. So we have a 25 in the left coronary cusp. We have had a 31 in the non-coronary cusp and a 29 in the cusp of the right coronary artery. For that reason, we used a 27 for the left coronary cusp. We measured a 29 for the non-coronary cusp after moving the commissure a little bit into the non-coronary sinus. Now I try to mark the suturing line below the native commissure, and then you start suturing from the new nadir, let's say it like that. And here you can see the right coronary cusp is already implanted, the first commissure is done. And then this is important, this is the native commissure, and your suture line is below this native commissure, as you can see here. The principal procedure is the same. You are suturing your dots from the leaflet. In the beginning, the distance is a little bit closer. And once you are passing the native commissure, you go upwards on your line, which you have drawn, as you can see here. Then you have to do the rest of the stitches in the aortic wall, because this will be your new neocommissure. Also, the pre-last stitch is a big bite. This could end up already in the native commissure, like here. And then it's the same. This is the last stitch. Here was the commissure. Here is the native commissure. And then you have the 29, because this is now smaller and you are creating the neocommissure. Here is now your nadir to start. Here's already the end for the other one. And then it's really the same procedure, just implanting the leaflets following your new lines as you did that usually. This is a pre-last stitch, and here is also the pre-last stitch from the other leaflet, and I try to put these already at the same height usually. And then you can see the last stitch. And after that, you are creating your commissure as usual. The rest is as usual, just penetrating both leaflets with the additional suture and try to get the configuration as you usually get that. And then you have your final valve at the end, and here is the original commissure, and you can see that you have a more symmetric valve by moving the new commissure towards the non-coronary cusp. So let's focus for the last minutes on AVNeo in insufficient bicuspid aortic valves. So the question is when to repair a valve and when perhaps it's better to resect the native aortic valve and go for something like reconstruction or even replacement. So the question is repair or reconstruction? Advantages of aortic valve repair, of course, are a long-term durability. So the native valves, there's nothing better than that. Low risk for endocarditis. Perhaps we will hear a little bit more about that later on. The native valve usually has an excellent hemodynamic. No permanent anticoagulation is also needed after aortic valve repair. And by that, you have an improved quality of life. So, but there are some limitations of aortic valve repair. And these limitations are very nicely worked out by the group from Schaeffer's. So here's one example, a degree of the commissures which are able to open of less than 160 degrees. This is a risk factor as shown by this group for reoperation. So another problem is, beside of the orientation, the aortic valve dimension. So an annulus above 29 or equal to above 29 also leads to a higher degree of reoperation, a higher rate of reoperation. Another problem seems to be the use of any kind of patch material. So they compared also a group of aortic valve repair patients with no pericardial patch implantation and a group which has implanted any kind of pericardial patch material. And as you can see here, the outcome was much worse. The same was published by our group last year. So as soon as you need to implant any kind of patch material because you have to resect the raphe or whatever, and reconstruct that by patch implantation, the outcome in bicuspid aortic valves is very poor. So in these cases, AVNeo could be possible an alternative treatment option. And for that, we try to evaluate in our patients. So you have seen in the beginning, we have treated 22 patients who has mainly an aortic regurg with AVNeo and compared that to our 61 patients, bicuspid aortic valve patients who underwent repair. So these two populations, the data are so far unpublished, so you are the first to hear about that. So 61 patients underwent aortic valve repair, 22 patients underwent AVNeo. So the degree of regurg was much higher in the group of AVNeo. So the underlying VTM was much more severe in this group. The peak gradient was 15 to 16 in the repair group and 21 preoperative peak gradient was 21 in the AVNeo group, and it differed a little bit regarding the mean gradient. So the mean gradient was already a little bit higher preoperatively in the AVNeo group. That reflects a little bit the strategy that if we have something like a raphe which is a little bit calcified, which has to be resected or something like that, that we have a little bit a higher gradient in the AVNeo group. But the effective orifice area in both groups were absolutely identical. Ejection fraction was identical, left end diastolic diameter was identical, and the size of the annulus was also identical in both groups. But if we compare the early hemodynamic, which you can achieve by repairing a bicuspid aortic valve, and if you do so, you ends up with two leaflets at the end, which has this fish mouth configuration at the end. Or if you replace or reconstruct the valve by autologous pericardium with three leaflets, which has a symmetric orientation, then you can achieve a much better hemodynamic. Here is given the time of discharge and the mean pressure gradient. And you have here mean pressure gradient in this aortic valve repair group above 10. So it's around 12 to 13 millimeter mercury. And in the same group or a comparable group after AVNeo, you have a mean pressure gradient. It's something around 5 millimeter mercury. So the early hemodynamics seems to be much better in this kind of patients. And we compared the effective orifice area. As I mentioned preoperatively, between the repair group and the AVNeo group, there was, for the effective orifice area, there was no difference with 2.9. If you compare that at discharge, the AVNeo repair group goes a little bit down with the opening area because of the repair strategies which are needed to get a competent aortic valve. On the opposite, the AVNeo group has a significantly larger effective orifice area at the end because of tricuspidization. So with this, I would like to summarize my talk. So bicuspid aortic valve is not a rare malformation. It appears in 1 to 2 out of 100 people. So perhaps one of our group who is listening today will suffer from a bicuspid aortic valve. Bicuspid aortic valve patients are usually below the age of 60 years at time of surgery. Biological prostheses have an impaired long-term durability in this patient population. AVNeo could be an alternative in these patients. The definitely goal for AVNeo has to be symmetric tricuspidization. Don't go for two leaflets. Every time go for a symmetric tricuspidization. Symmetric tricuspidization often, but not always, needs creation of a neocommission. Tricuspid AVNeo shows improved hemodynamic compared to bicuspid aortic valve repair, as I have shown you at the end. With this, I'm at my end and I'm open for questions if you want to discuss. Thank you very much.
Thank you, Professor Krane. That was excellent talk. As always, I learned quite a bit again from you, so I do definitely appreciate that. Dr. Bakhutashvili, do you want to make some comments, please?
Yes, hello everybody. I'd like to congratulate Dr. Krane for a beautiful presentation and thank you for sharing so unique materials which he has for but maybe because with the treating of the bicuspid aortic valve. And we know that it's this, as he told already, this bicuspid aortic valve, it is occurs in about 2% of population, but it has more tendency to become the stenotic or for fail. So it is a real problem for population. So it's there is good solution for people who would like, who is younger and who is not like to have warfarin treatment in during whole life. So this tricuspidization is a good and for my point of view a favorite method for the patients with bicuspid valve. So and again, congratulations one more time. So I have a one question when to Dr. Krane, Professor Krane, that when, as you described, there is when it's type O position of the bicuspid aortic valve, then in some position, it happens then suture line, it's pass, more than half of suture line pass out of aortic fibrotic ring. And sometimes if its bulbus is a little bit aneurysmatous, does not make its discomfort to make so long line of out of fibrotic link. Because in last week I had such a case when I promised to young guy to do Ozaki procedure. It was type 0, but when I took out this calcified valve, it's for me it was not comfortable feeling to make so big line as a 2 new commissures and also 2 new nadir to make this whole tricuspidization. Finally, I switched to mechanical valve. Patient was not so much happy afterwards, but I try to do best for him. And this is one question. And so this is my question, please.
So you are absolutely right. The type 0 morphology, and I'm very happy about the fact that this is the rare morphology within the bicuspid aortic valve scenario, often leads to a long suturing line out of the annulus. And it is sitting in the part below the annulus, in the myocardial part, this suturing line, which is sometimes not very strong. And I have to say, we have, I guess, 4 failures intraoperatively, where we switched, as you described, to mechanical or biological aortic valve replacement within the same procedure, because these kind of valves are the most difficult ones to end up with the tricuspid aortic valve on the same height at the end, having the neo commissures with the one native commissure. So these are definitely the most difficult valves to treat. Another problem in this type 0 configuration is especially in the configuration when both coronary osteas are on the same leaflet side. So then you have often a conflict that you do not have enough space between both ostia to create this neocommissure, not coming too close to one of the ostia. So in these cases, I would definitely recommend go for replacement. This is a nicely established strategy to treat patients, and this is really, really difficult to do.
Thank you very much. I take opportunity to ask another question. You have a big experience with the tricuspidization. So, which place, as you told, you have 4 failures of the during the operation, and which place is it, nadir or commissure, most fragile place for this tricuspidization? Where it happens mostly is this problem.
Yeah, and in none of the cases I can tell you exactly. So we did the reconstruction, followed the rules, but we have had in all converted cases something like an insufficiency of a degree 2. So that's why we decided for a second one to convert. And I have, unfortunately, I have to say, I do not have learned so much that I can say, oh, I did this completely wrong. It doesn't look good. Here the stitch was bad, or the commissure was wrong, the sizing was wrong. Perhaps the number is too low to tell you something about that. We just recognized the result wasn't good. And in this cases, of course, for the patient's sake, we switch to procedures. But if you If you compare that to our general number today, we have probably something like 170 cases, because the analysis, which I have showed to you, was from September last year, and we converted 4. So it's not a high number. So usually we can say the treatment is successful in more than 90% of the cases, 95.
Thank you very much for absolutely competent, confident answer for my questions. And I like to congratulate again for your beautiful results of the tricuspidization. I would like to comment also.
Difficult word, yeah.
Yes, it's very difficult word, absolutely. So I would like to comment also. It's I have also it's experience with AVNeo